today, and I'm very excited about this special session this morning where we're going to be covering topics about peripheral arterial disease and aortic stenosis in women, as well as heart failure in women. Now, we have, unfortunately, because of some faculty had to change their flights, we're changing the order of the speakers. And we're also, after each speaker, going to do 5 minutes of Q&A for each speaker rather than the full panel discussion at the end, because 2 of our faculty have to leave to catch a flight. But there is going to be time for Q&A, so save your questions. It'll be immediately after each speaker. So going a little bit out of order, our first speaker, I'm delighted to welcome Dr. Roxana Mehran, who is the endowed professor of cardiovascular clinical research and outcomes and a professor of cardiology at Mount Sinai. She's the director of interventional cardiovascular research and clinical trials and the director of Women's Heart and Vascular Center at Mount Sinai Heart. She is going to be speaking to us about an important topic that doesn't get a lot of attention, and that's peripheral arterial disease, a call to action for women in peripheral arterial disease. Dr. Mehran, please welcome to your talk.
Good morning, everyone. What a delightful morning. You can't imagine that there's actually going to be a hurricane or what have you, but and it's been a fantastic 3 days here with Dr. Mikos and Dr. Taub. Thank you so much for having me, and thank you for putting in this very important topic of peripheral arterial disease and a true call to action. I will go over some of the data that I think are quite daunting. So obviously, this is a pretty common morbid and potentially deadly disorder that is under-recognized, undertreated, especially comparison to CAD, but most of the patients who are affected actually do have adverse peripheral arterial limb events as well as cardiovascular events. If you look at the global prevalence of peripheral arterial disease by sex, it was through the Lancet Commission, which I'll discuss a little bit later, when we were looking at the global burden of disease data and trying to figure out the sex differences with all of the diseases that pertains to the heart. Peripheral arterial disease prevalence is actually higher, and I would imagine that this is an underestimation of what the true numbers are, because women tend to have atypical symptoms and not get the evaluation that they deserve for the diagnosis. And if you look at the global prevalence from the 2019 data, it's 1,735 per 100,000 women around the globe. It's quite prevalent. The differences are also important for us to note because it really takes into account clinical, biological, and societal, the kinds of things we don't think about that leads to a possible increase in prevalence, a poorer treatment outcomes, increased mortality, and worse quality of life. So let's begin with amputations. So there is obviously below and above the knee amputations, and if you look at the ratio between below the knee and above the knee amputation, women, the ratio compared to men, women are having higher rates of above the knee amputations. This is devastating if you can imagine what it does to the quality of life of humans who have above the knee amputations. And when you see that that ratio between men and women is different, and that the predictor of a transfemoral versus a transtibial amputation, female sex rises to the top, as well as being non-white or black. The income is there when you're in the 0 to 25th percentile, 26 to the 50th percentile. Why should it be that way? Why is this happening? And I think it's very, very important, even the insurance status predicting that there's more transfemoral amputations compared to transtibial. If we look at some of the postoperative complications and compare men and women, often we see the very, very important infections being in the wrong direction for women, more bleeding, and higher mortality. And is it because of sex, or is it because by the time they come to us, they have so much more comorbidities, so much more disease? It's really difficult to tease that out. Because their symptoms are atypical, the examination is different because women are more likely to have greater functional decline and reduced walking parameters and quality of life. And the diagnostics, when they present, they usually have multivessel disease. The symptoms are atypical, leg cramping, but you would imagine leg cramping at rest, we should be evaluating ABIs in these patients. And of course, critical limb ischemia, that's how they present. And if you look at the PAD presentation from over 8,000 men and women going a randomly selected population in Sweden, and you know these data are well controlled because every patient in Sweden is evaluated and in a database, you see immediately that in these asymptomatic PAD is more prevalent in women, as is severe ischemia. And when you look at the proportion of emergency hospitalizations, women are more likely than men to be admitted emergently because they're waited too long. They show up with critical limb ischemia. They have much, much higher rates of that, and of course then much higher morbidity, mortality, and of course a much more advanced stage at the time of first diagnosis. What are we missing in women? Well, we're not doing a good job in their important management of all of their hyperlipidemia, hypertension, antithrombotic therapies, supervised exercise therapy, and revascularization. And to go through that, you could just see that there is much, much lower odds of women achieving the target LDL. Men are more likely to be treated with more intense antihypertensives. Women are less likely to get antithrombotic and antiplatelet therapies, probably because we're afraid of them bleeding. And then that supervised exercise, there are very small studies that actually suggest that there is less response to supervised exercise therapy in women compared to men. And then there are some old data that show that there's lower use of revascularization in women. And if you look at the overall for men and women, the overall underutilization of secondary prevention therapy when we diagnose PAD is quite high. It's higher in women compared to men, but it is high all around. We really have to do better in PAD diagnosis and lifestyle management and, of course, secondary prevention. You could see that this medical management is much more pronounced in women compared to men in lipid-lowering, cardiac preventive, and antithrombotic antiplatelet therapy. And they are less likely to undergo surgery for PAD compared to men. Whether it's for a AAA, women are less likely to undergo surgery for AAA, 25% less likely, and less likely to undergo surgery for PAD versus men for the same disease. And it may very well be that their comorbid conditions gets them declined for surgery. We just don't know enough data about this. And this small study showing deriving less benefit from exercise, supervised exercise therapy is something that I really believe we need to pay more attention to. What is the issue here? And I'm not so sure because the data is so sparse for women. The risk factors are similar on many, many places like hyperlipidemia, traditional risk factors, but there is other risk factors like environmental pollution, socioeconomic status that much more often affects women compared to men. And we know that these non-traditional risk factors have some important relationship to endothelial dysfunction. And of course, we also know that for sex-specific preeclampsia, menopause, and other early menopause and other important female-related risk factors have important implications in PAD. The major one is smoking. The data from the Women's Heart Study, when adjusted for age, the risk of PAD is 10-fold higher in women who smoked 15 cigarettes per day versus women who never smoked. Former smokers, even if you quit, had a 3-fold higher increase in peripheral arterial disease versus those who never smoked. And there's a dose-dependent response. And when we see that young girls are starting with smoking and vaping products, it really is how it gets started. And we need to really, really think about this. There are important, well-established risk factors like diabetes, hypertension, suboptimal exercise, and high lipid levels. But what we know that there is a lower prevalence of these well-established risk factors in women versus men, suggesting that we need to look at these under-recognized risk factors because the prevalence of PAD is that much higher in women. And in fact, we need to look at these in terms of very important healthcare, the societal issues, the important biological issues that we need to think about. And other factors play a very, very important role. The paucity of data in PAD in women in clinical trials is unbelievable. Take a look at this decade, very, very recent decade of 2011 to 2021. The average female recruitment is almost always around 20 to 25%. Rarely does it get to 30%. And we work very, very hard. Women are more reluctant to come into clinical trials. They are less often screened for PAD, so therefore they don't make the criteria to come in, and we've got to work around this. So this lack of data, where we now have to have urgent need for data on women on the true prevalence, we just don't have any idea because of the underdiagnosis, the clinical presentation, understanding better. These are the unmet needs, the role of well-established sex-specific and under-recognized risk factors, and of course, important optimal therapies and outcomes. Pretty much the whole gamut has no data. So this is an unbelievable next area to really focus on. And for the younger trialists in the audience, think about this for your next AHA grant. Think about this because it really is an unmet need, and I believe a very, very important place to actually reduce the global burden of cardiovascular morbidity mortality if we diagnose PAD earlier and get to it. So diagnosis is important with the physical findings that we already know. There are important guidelines that are out there, and of course, looking at hair loss, bruise, dystrophic nail changes, and of course, pallor and dependent rubor in the limb. Many patients are not being well examined. And if you don't do a good physical exam, you are not going to find this. And you will end up with women presenting with critical limb ischemia because no one bothered to take the socks off in the physical exam room, or feel the pulses, or do the test in dependent rubor, for example. And then, of course, the testing. Very, very important. ABI, PVR, treadmill testing, duplex, and then more advanced testing like MRA and angiography. But the very simple ABI, which is an ankle brachial index, which is cornerstone of PAD assessment, is very, very difficult. The data actually suggest that the ABI there's a lower range of ABI values in women, but if we change the guidelines according to that, we may end up having much, much less diagnosis. So we really have to pay attention to this, and we don't understand why is it. Are there important endothelial changes that give a different ABI sort of threshold for women compared to men? We just don't know. And there are important limits in certain circumstances, like calcific vessels where there's false elevation, or not understanding the anatomic information. And of course, the solution on there is very important segmental pressures and waveform analyses that are often missed and not done. There are wonderful algorithms for diagnostic algorithm for PAD, but first and foremost is a good history physical exam assessment of risk, suggestive of PAD, and then moving to ABI. And then, of course, very important when you are in these suspicious areas to not stop and say, oh, you're fine, but go on further to do these segmental pressures, graded treadmill testing, or even anatomical assessment with more advanced imaging. This is a fantastic article in JACC in 2017 with the diagnostic testing for PAD, and I think it's a very, very nice algorithm that you can go through to really get to the answer. Many of us are not following these algorithms. Importantly, the therapies for PAD have important prevention in death, MI, and stroke with antiplatelets, lipid-lowering agents, ACE inhibitors. For improving symptoms and quality of life have to do with exercise and maybe perhaps endovascular intervention and surgery, and of course, drugs like silastazole. And you can save limbs if there is important critical limb ischemia with more advanced therapies like endovascular interventions or surgery. But the reducing of the cardiovascular morbidity and mortality in patients with PAD requires all of this. And so we need to make that diagnosis of PAD to then really be focusing. We should be doing this in all of our patients. But as soon as you have PAD, it really is a risk. The risk elevation goes up by many, many factors that we have to be paying attention to. Take a look at the ACC/AHA guidelines back in 2016 with Class 1A for all of these things. Lipid lowering, statins, antihypertensives, antiplatelet therapy, as well as silastazole. Yet, they're not deployed very, very well. The adherence to guideline-based medical therapy, which we know reduces MACE and major adverse limb events, are absolutely well documented. Intensification of lipid lowering in PAD in reducing limb events with avolocumab or other important, there are important limb-saving therapies that can be done with just lipid lowering and getting that LDL below the target of even less than 50 in these patients, reducing major adverse limb events with a simple intervention that we often are not doing in PAD patients. And then, of course, very important data on patients with antithrombotic therapy, the Voyager PAD study, where it was the largest 6,500 plus patients undergoing with symptomatic lower extremity PAD who underwent peripheral revascularization were randomized to rivaroxaban twice daily versus placebo, with a major reduction of the very, very important primary outcome, especially in women. Take a look at that in women. But, of course, more unplanned index limbs revascularization in those. In Voyager, overall, there was a major reduction in major adverse cardiovascular and cerebral vascular events. And you can see that there are important sex-specific analysis. Connie Hess basically showed this. You see that women and men were at a very similar risk. It seems like if we went longer, maybe beyond 5 years, maybe women would do better. But yet, knowing these data, very often we're not seeing rivaroxaban used in these patients. In fact, if you look at the sex analysis, you're seeing both on the intention to treat, very important evidence for the overall group. In females, it's crossing the line of unity, but there is no P interaction. It doesn't mean that we should not be enhancing and giving these therapies to these patients. One of the very important issues in the sex analysis was the premature treatment discontinuation, which was much more frequent in women compared to men, and that may have something to do with some of the bleeding complications that's more prevalent in women. The COMPASS trial is another trial. This was a trial of high-risk patients with CAD or PAD 27,000 patients randomized to rivaroxaban 2.5 milligrams BID plus aspirin versus Riva alone at 5 milligrams versus aspirin. The trial was stopped early for the major benefit of rivaroxaban and aspirin in reducing mortality. The DSMB stopped the trial. Then the trial went on, and of course, a year ahead of its expectations, because of the overwhelming efficacy that was seen in the rivaroxaban arm. And you can see that here, the lowest event rate, even after the trial went on to go into its third year of exposure and follow-up, and the curves separating almost very early on in that first 6 months in favor of rivaroxaban plus aspirin. But this particular strategy is yet still not used in many of our patients who have CAD and PAD. In fact, if you take a look at the outcomes on men and women, there was only 22% women, as usual, not enough women. And we saw very similar, no difference, sex-related difference. They both were importantly benefiting from this. And in fact, you could see, yes, overall rates of death, stroke, or myocardial infarction was absolutely in favor of rivaroxaban plus aspirin compared to aspirin alone. And you can see that if you look at death of any cause, it looked like there was maybe a little bit more of a benefit in men compared to women, more bleeding in both, and of course, overall rates of NACE, or net adverse clinical events, or very, very terrible bleeding was no different and had no issue whatsoever. So what are the indications for revascularization? And I think, why is it that women are not often referred to revascularization? For sure, it's critical limb ischemia, acute limb ischemia, we know that. But I think it's also lifestyle limiting claudication that then limits that patient to be able to exercise and get healthy. And so it's yet another indication that is often overlooked, especially for women. It is not to save their lives or to improve and have less MI. It is to improve the quality of their life and their ability to do more walking, more exercise. And I think you could see right here the very important presentation and why you have indications for revascularization. If you have claudication, you really want to see that there is a good patency, there's limb salvage, and of course, very, very important in both acute and chronic limb ischemia to salvage that limb and get away from amputations. And I think for critical limb and acute limb ischemia, that revascularization becomes urgent, absolutely urgent within the first 2 weeks for critical limb ischemia and as early as the first 12 hours in acute limb ischemia. But let's go back to the basics. Despite all of this evidence, 30% of patients do not get arterial testing prior to important major amputation, which means that we are absolutely ignoring the very simple measures of PAD diagnosis that I already discussed: physical examination, ABI, imaging, talking to the patient. And one of the most amazing things from this particular issue of looking at all of the amputation amongst the Medicare beneficiaries from 2000 to 2010 in that entire decade, what it showed that being a woman was associated with a lower likelihood of testing compared to being a man, even though you were undergoing. So many of these women never even had testing. In 2012, we had a call to action, and this was an AHA scientific statement that got a lot of attention. This is 10 years ago, 11 years ago. This was led by Alan Hirsch and so many of the best people who absolutely said that peripheral arterial disease in women is a very, very huge issue for us to tackle, to evaluate, to diagnose. And where are we today? Well, we continue with the challenges that I've already spoken about for the last 2 decades. The most important one being the underestimation of risk and low awareness of PAD in women, and the fact that we still have not addressed the underdiagnosis, how we could actually improve it with screening, the underutilization of guideline-directed medical therapy, identifying that vulnerable population that is not diagnosed, the access to care, facilitating that early diagnosis, and most of all, what I'm really committed to, and maybe even thinking about designing clinical trials only in women. So there are many women trialists there who are, I'm looking at you, Fatima. Let's think about that for an AHA grant. Let's look at how we could do this, because we need to turn this around. And of course, addressing the uncertainties of both sex-specific but also under-recognized risk factors, and then the idea of why is it that women are not responding to something that seems to be working very well, a non-invasive exercise, supervised exercise therapy that we know works so well. The commission that I was very lucky to lead, and Brigitte Vogel was the very first author of this. This was published in 2021, and we, of course, were absolutely focused that by 2030, we would reduce the global burden of cardiovascular disease, and gave our top 10 recommendations. And we devoted an entire section to PAD. And here are the key points that all of our research came up with. PAD remains underdiagnosed, undertreated in women worldwide, not just in the United States, and not just in underdeveloped countries. In fact, in the United States, in certain zip codes, the underdiagnosis of both women and underrepresented minorities is daunting and unacceptable. Further efforts are needed to increase awareness about that high prevalence of PAD in women, but we absolutely need to get our arms around that, the true prevalence, which could be a lot higher than what we already imagine it to be. And we believe that allied health professionals, not just physicians, but the ones who are actually closer to our patients, are wonderful nurse practitioners, physician assistants. They have to help us, because we're under, well, you heard all of this, the workforce and what's going on, and our systems telling us you have 10 minutes to see the follow-up patient and 30 minutes at most if you're lucky with a new patient. And these require a lot of history-taking, understanding what's going on beyond just what's in the chest and what's extending to the periphery. And I think having them help us in screening and a very, very quick, easy, and non-invasive tools like ABI that's underutilized, I think will help us establish and understand better how we could absolutely see these patients, get to them, and start the medical management and the secondary prevention of very, very important issues. I want to thank you for your attention, and I look forward. I flew through this because I wanted to make sure there was time for us to talk.
Well, thank you for that great talk. Where we want to sit down. So for each speaker, so please come up to the microphones. We have about 5 minutes for questions for Dr. Mehran. I'll start with a question. So, you showed this fantastic data from the COMPASS study. I mean, clear, important, meaningful benefits in reducing MACE and male major adverse limb events. But in clinical practice, I really see that low-dose rivaroxaban is really underutilized. And I suspect that people are, concerned about bleeding, especially because, patients are maybe on other anticoagulants. And of course, that's given with aspirin. So, in dual antiplatelet therapy, DAPT, there's calculators, the DAPT score, the precise DAPT, where you can try to figure out, is your patient more at risk for bleeding or more at risk for ischemic vascular events? Is there some kind of, COMPASS score? Like, how do you assess bleeding versus who would derive benefit when we're thinking about low-dose rivaroxaban, particularly in patients with PAD?
So, Erin, you hit the nail right on the head. It's really, really very, very difficult. It's not just about one size fits all in terms of antiplatelet and antithrombotic regimens for patients with CAD and PAD. And I will say that, the idea of evaluating the risk of bleeding, the risk of ischemic events, and balancing those is something that we're all looking for, that sweet spot where we would get the best benefit on reducing ischemic events with the least amount of bleeding. And how often can we get there, and what tools are available? There are several risk scores. I'm responsible for several of them actually out there, but especially for antiplatelet regimens. And for combination therapies now, we are pooling the data of all of the AFPCI data to look at actually how we might be able to address this balancing the ischemic and bleeding risk. I think the future is going to be all about artificial intelligence and machine learning, and I'm actually involved in collecting large data sets to come up with best algorithms that fit, but there's no clear single answer for anyone. On the COMPASS side, and the underutilization of the COMPASS strategy is something somewhat of an enigma to me, and I don't understand. And I think a lot has to do, as I talk to my colleagues and practitioners, is that there was never a plan of how do you come off clopidogrel and get on to rivaroxaban, for example. What does that switch look like? How do we deal with this after a PCI or after an event of whether it's a stroke or an AFib or whatever it is, and it becomes more of a difficult switching where the direction is not there for physicians. So I think these algorithms are going to come back with some tools, but at the end of the day, you still have to make those important judgments. I don't have a clear answer for you, I'm sorry to say, because it is very, very difficult. If you look at the number of permutations, it's somewhere around 2.2 million permutations of antiplatelet and antithrombotic regimens in patients with CAD and PAD at different presentations and duration and indications. So I can't tell you which one is best. It's very, very difficult. So I think the future will be AI and machine learning.
Okay, great. And I have one more question. Again, if anybody wants to come up, we probably have time for one more question from the audience. But my question is, so we heard a great talk this morning about the benefits of SGLT2 inhibitors. They seem to be a miracle drug. But, there was some initial concerns from Canvas about SGLT2 inhibitors in patients with PAD and, whether that's agent-specific or class-specific. So where is the current thinking about, and if you're going to start a patient with PAD on SGLT2 inhibitor, what do you recommend, to them for precautions?
I personally, I don't make too much of those data, to be really honest. I think we need to learn more about SGLT2 inhibitors. There are fantastic drugs that are actually underutilized. And of course, in PAD patients, we're just a little bit more careful. We'll do a little bit more surveillance, but I'm not really buying the data. It'll be hard to sell me data like that when they're slicing and dicing and taking a look at multiple subgroups and things like that. But I think it's an important one to evaluate and continue to keep our eyes on. But let's make sure that we go back to the basics for women. When a woman comes to your clinic, please take her socks off, her shoes off. Please feel her pulses. Please see how well perfused she is, and make sure that you absolutely pay attention to peripheral arterial disease, which could be one of the most daunting complications that could happen to that patient with a loss of a limb that usually is above the knee amputation.
Okay, great. I think I have time for one question from the audience, and then we'll let you go.
Yes, I'm a general cardiology fellow going into interventional cardiology, and you brought up a great point about underdiagnosis of women in terms of having PAD. The other issue being misdiagnosis. A lot of these patients are seen in primary care first, and they might bring up, foot pain, for example, and be labeled as fibromyalgia or chronic pain, et cetera. So I guess my question is, how do we get these people into a specialty clinic like a cardiology clinic or another clinic like a vascular clinic where they can actually get evaluated? How do we reach out to the community and raise that awareness?
Yeah, no, it's a really, really good question. Thank you for that. I think one of the things is to educate our healthcare providers for not just women, but also men. They're also but women more so. They'll say, oh, this is fibromyalgia. Oh, it's a neuroma. It probably is, it'll go away. It's your arthritis. and of course, never really assessing the arterial blood supply, et cetera. And I think that's a very important question. We need to continue to educate our healthcare providers and do a better job, no question about that. But thank you for that question.
Thank you.
Well, thank you, Dr. Mehran. We're out of time, but have a safe flight, and we're so grateful that you were part of our conference. So we got, yes, thank her. So we got a next fabulous talk upcoming. So we have Dr. Anu